Welcome to Casualty Live with me, Dr. Gino Njema. This is a show where every conversation is a step towards smarter decision making in the moments that matter. Together, we seek to learn, respond, and ultimately save lives. Hi, everybody. Welcome back to Casualty Live. I'm so excited to be back again. Welcome back. Welcome to episode 4, where we talk about trauma fundamentals. Actually, this topic was requested by one of you, so I'm glad to be having this conversation. Karibuni. So, when we work in our emergency department, trauma is hardly ever something that you anticipate. They usually just come in. Sometimes there can be multiple patients who are brought in. And when these trauma patients come in, no single clinician can be enough to take care of these patients. So in that regard, trauma is a team sport. It's always a team sport. And today we're going to talk about how high stakes teams navigate these trauma patients, from the structured approach to the patients to the different roles each team player has to play, and how to communicate within the team to ensure that we save a life. So that's what we're talking about today. Trauma fundamentals. Karibuni. Right, so let's jump right in. Why should we be talking about trauma today? Why is trauma management important in our local context? Well, simply put, and unfortunately, Kenya has a very high trauma burden. If you're working in the emergency department, it's a very common complaint. You'll find a lot of patients coming in with one form of traumatic injury or another, and it's very, very common. And it expands all the way from your road traffic crashes to your fall from heights, to your building collapses, to your weaponized attacks like gunshot wounds, stabbings, and things like that. So it's a very high burden complaint and a very common complaint in our emergency department. So we need to be prepared and highly skilled to deal with it. So, like we always say, so we can always just save a life, right? So today the patient context we're talking about are the trauma patients who have the high risk injuries. And by high risk, I mean a life-threatening injury or a limb-threatening. So high morbidity and mortality, right? Those are the injuries we're going to be focusing on, as opposed to maybe like the child who fell on the playground. That's not our focus for tonight. And just to reiterate and get down to that, our falls from heights, significant heights, usually like twice the person's height. So the kids who fall from balconies, construction workers who fall off of a construction site, or even someone who jumps off of a high height. That's one of the things. Our road traffic crashes. This is an increasing trend, especially with more motor vehicle use, especially motorbikes, our boda bodas. That's very common, and especially our pedestrians often injured in these situations. Our burns patients, our like if you're a miner and the mine collapses on you, or if you're in a house and the building collapses. We talked about our penetrating injuries, gunshot wounds, stabbings, things like that. So that whole scope of high risk trauma, which has high morbidity or high mortality, that's the context of our patient. Those are the ones we're going to be talking about tonight. Okay. So these patients who have high morbidity risk and mortality risk, it's important to focus on them because exactly that, high morbidity mortality, but they will also need a lot more resources than the low risk traumas. Okay. And by resources, I think one very important one is human resource. Okay. We're going to be talking about our trauma team. So I hope we all have trauma teams in our hospitals. And if we don't, it's something that we should really, really consider establishing sooner rather than later. Because, like we said, trauma teams will require a lot in terms of also manpower. Who is going to fix a cannula, who is going to secure the airway, who is going to put a chest tube, who's going to do the ultrasound, things like that. And all of that can't be one person, right? So that's why we like a team approach to this. A trauma team is very, very fundamentally important to our high risk trauma patients. Okay, so who is this trauma team? Okay, so a trauma team is a group of medical personnel who are trained in how to assess and manage the trauma patient. Okay, so please, these teams should be made before the trauma patient arrives. as much as we work in emergencies, you can always try and prepare for what could come in. Okay. So your trauma team should be preformed, and every day, whoever comes on the ground, whether it's like the anesthesia team, they know that if there's a trauma call or a trauma code activated, they're the ones to respond. If it's somebody in the emergency department, there's someone who knows, they're the team leader. Radiology, there's someone who knows. Yeah. So it's a preformed group of medical personnel who come together to deal with a trauma patient. It has a lot of different members: the emergency department team, the doctors, clinical officers, nurses. It has surgeons, anesthesia team, radiology team in terms of, especially because of point of care ultrasound and portable x-rays as well. And then any other support personnel who would be qualified and equipped to join the trauma team. So that trauma team comes together when needed, and they work together to assess and manage the trauma patient by identifying the injuries, starting with life-threatening ones, intervening appropriately, and making a plan for definitive care, whether that's theater, radiology, or transfer out. Okay. So that's what your trauma team is supposed to do. Those are the people who come together. It doesn't mean that every trauma team should have all these people. Depending on your resources, it can be even 3 people or 6, 7 people. Okay. But the most important roles that you need to make sure are covered, first and foremost, is your team leader. So your team leader is the one who organizes everything and gives the orders and looks at the big picture and tries to see, okay, this patient has an airway problem, and tells the airway person, please intubate. Or sees that they need blood, gives the order for the blood to be prepared, right? Things like that. So the team leader is the most important and should be constantly there in all trauma teams. They're the ones who coordinate the effort of the trauma team to the end of saving the patient's life. Okay. Another person you need is an anesthesia person, somebody who is skilled at airway management. Okay. So most high risk trauma should be managed in a center where they have theater capabilities. So with that, we assume that there will be somebody from anesthesia, whether it's a CO anesthetist or a medical doctor anesthesiologist, but somebody who can work on the airway, from simple airway maneuvers to more advanced ones, which can include intubation. And intubation is from the simple, quick RSI to the more difficult airway management algorithms and pathways. Okay. So team leader, airway person who also bags, and then somebody who is going to do your circulation and your medications. So fixing your IV cannulas, if there's a massive hemorrhage, somebody can control that. Starting your fluids, removing blood samples, starting your blood. Then somebody who's going to document all of this, because if you don't write it down, it didn't happen. Okay. So you have to document everything clearly, the time each intervention was done, what the interventions were, what the findings were. Okay. Then you can also have somebody to help with procedures. If it's a chest tube being fixed, somebody who can do that. If you need to do now you can also have like your radiology team, or it can be a member of your ED team, somebody who can do a point of care ultrasound. So that's important. Radiology team can also bring a portable x-ray if available. So your trauma team should have those key roles. And then what is also very helpful is having somebody who is your runner. Can be a nurse, can be a medical student, can be a clinical officer, can be even support non-clinical staff who can run to the lab, get blood, things like that. Because again, it's a coordinated effort. So if you have that team in place even before, and everybody knows their roles, so when the trauma comes, they're just moving like a well-oiled machine, because everybody knows what role they're doing. The team leader can also assign roles, and you do what you're supposed to do, and you communicate back. The communication is a closed loop communication. If I give you an order, you acknowledge the order and tell me when it's done, so that I know the next thing that we're going to do. Yeah, so that's what the trauma team is, and who the members of the trauma team are, and the point of the trauma team. Another question that you can also often get is, when do we activate this trauma team? Trauma team activation, there's some certain criteria. Even in the Casualty app, we have a list of criteria for activation of the trauma team. And it basically just includes the mechanism of injury, like is it a gunshot wound, is it a fall from height, were they ejected from a vehicle, and then the injuries that the patient has, right? Do they have a suspected spinal cord injury? What is their physiological status, like their BP? Are their systolics less than 90? Are they having trouble breathing, meaning they're breathing too fast, above 30 breaths per minute, or too slow, less than 10 breaths per minute? So things like that, based on the mechanism of injury and your patient's physiological state or injuries that they have sustained. So we can all have a look at the Casualty app in the trauma team activation criteria, and that can guide you. And you can also plaster this on your emergency room walls so that everybody is in the know. Okay. Yeah. Okay. So the next thing I want to talk about is, how do we become a highly skilled trauma team? How do we become these highly skilled and trained people who can be part of the trauma team? Unfortunately, it's not fully integrated into all the curricula, but there are additional courses that you can always do on top of like your primary training to help you be able to manage trauma better. Okay. So there are different ones. The main one we're going to focus on today is called ATLS, Advanced Trauma Life Support. So this is a quick short course which takes you through how to approach trauma from a primary survey point, secondary survey, adjunct, and all that, and how to intervene appropriately. It also, for those who are trained in ATLS, it emphasizes a key language. You'll hear us keep saying common language, so that everybody on the trauma team is speaking the same thing and can work together. Okay, so that's number one. And for our nurses, it's the same, but just advanced trauma care for nurses. It's a similar course where you're taught how to approach these patients, how do you treat them appropriately, which are more high risk, how do you start the process of managing these patients as a team as well. Then there's also the pre-hospital trauma life support course. So this is good for anybody who's interested in the pre-hospital space. So our EMTs, anybody who's going to like arrive at the scene, or any intervention that will happen before the patient gets to hospital. This is a very good course. Then there's also a European trauma course similar to ATLS, which teaches a systematic approach to identifying and managing our trauma patients as well. Then there's also the tech course, the emergency care course, offered by EMKF to different sub-county hospitals in conjunction with the county government, to teach you on different emergencies, among which trauma is one of them, and similar principles of a systematic approach to trauma. So all these courses are available for different cadres, for everybody to take up and learn about how to manage trauma, so that when the trauma patient comes to your emergency room, at least they're guaranteed that they will get the best quality care, because you know how to approach these patients and treat them. Okay. So if you've not done one of these courses, maybe look into them and give it a go and get more information. In the absence of that, we still have the Casualty app. We have a trauma management pathway, which echoes the same principles. Now that we know who our team members are and what they need to do, let's do a quick run through of how to actually manage these trauma patients. So I'll just use the Casualty app guideline algorithm to take you through the steps that we need to look at. Okay, so first things first, start the triage. Patient could come in different ways, could be wheeled in on a wheelchair, through the emergency entrance from an ambulance and all that. So your first thing is to get a quick sample history where you get signs and symptoms, allergies, medications, last meal, and the events preceding the presentation. I think the most important part is the events. In terms of an ATLS perspective, we call it MIST, where you want to know the mechanism of injury, what the injuries are, if there's what are the signs and symptoms, if there are any interventions that have been done in the field, and all of that. A quick snippet of what happened. Then you want to look at your patient quickly and see what is the clinical state, okay? Then that's where you will need to activate your trauma team, right? And then when they come in, then they'll take the primary survey and resuscitations. And the primary survey starts with any exsanguinating hemorrhage. What that means is there's a massive bleeding that could cause loss of life if uncontrolled, right? So that's your first thing. You want to control any external massive hemorrhage that you can see. So that can be in the Casualty app, we have a step-by-step on how to address different kinds of bleeding. Is it something that needs pressure dressing? Is it something that needs a tourniquet? Is it something that needs suturing? Things like that. Then once that is controlled, you can reassess and check and make sure it's not bleeding through. Then we go to your C-spine clearance and airway management. So C-spine, airway and C-spine go hand in hand. C-spine, you can assess clinically, so from the mechanism of injury and from any clinical signs and symptoms. So they're the nexus criteria that you can get on MD Calc and have a look and see if the patient meets the criteria for immobilization. Immobilization while in the hospital, preferred is with the head blocks. In transit, I know we do a lot of C-collars and extrication and all that, but once you're in the hospital, head blocks is actually easier, and we're moving more towards that. Also because in our context, not everybody has a C-collar, and then there are moments where you get there and then the paramedic is like, okay, sasa nimekuletea mgonjwa nipatie C-collar yangu. So you might not have a C-collar, you might not have the right size, it's uncomfortable. So you can put the head blocks, which can be adjusted by patient and is easier. And they're very easy to actually make, very simple materials. So immobilize with the head blocks, or you can do blanket rolls if you don't have that. Then keep them in that until cleared radiologically. Okay, then you go to your airway, talk to your patient. Are they able to talk? Which means if they are, the airway is open and maintainable. Also stories about what happened, like if it was a enclosed burns, you'd be thinking airway at risk. So if for any reason the airway is at risk or the patient's airway is not open or maintainable, you want to secure that airway. The way we do that is by intubation, and not just any intubation, we do a rapid sequence intubation. Again, we have the algorithm in our Casualty app that you can also refer to and see. So that would be your first priority, because an airway that is not patent will kill you first. It's the first killer, right? Okay. Once you've maintained your airway or secured your airway, you want to go to breathing. So here your vitals are important. What is the rest rate? What are the SpO2s? If you can also get a blood gas, what are the PaO2s? You think about that. Then now you look, listen, and feel. What are the breath sounds like? Are there added sounds? Are they reduced? What does it sound on percussion note? What do you see on the chest? Is there like an open sucking chest wound? Those are the things you're looking out for. The interventions, so the supplemental oxygen. Remember, our critically ill patient, you start at non-rebreather and titrate down. Then if they have a sucking chest wound, you want to put a 3-way dressing. If they have a pneumothorax, hemothorax, you want to put a chest tube. If they have a tension pneumothorax, intervene. So you put a needle decompression and then prepare for a chest tube, which is definitive. So there's that. Then now for the ones who have hemothorax, how much has drained? Is it a massive hemothorax? 1.5 liters or more than, is it 200 to 400 ml in a couple of hours? You want to keep monitoring that. So the initial draw of blood, you must document how much it is, because if it is a massive hemothorax, you'll want an emergency thoracotomy. You want to talk to your surgeons, if not already there, right? Then once you intervene, reassess. If you put your chest tube, are the SpO2s better? Are the breath sounds starting to get better? Things like that. Then we go to circulation. In circulation, you're looking for other causes of bleeding that aren't overt, right? So you're thinking about mainly your internal hemorrhages are where you'll be thinking about. So are they bleeding in their chest? We've sort of looked at that also in breathing. Are they bleeding in their abdomen, in their pelvis? A good way to check this is, one, clinical exam is still king, because that'll help you pick up the hemothorax. On the abdomen, you might see some bruising, you might see some distension, you might see an unstable pelvis, and also palpate for an unstable pelvis, then put your binder, things like that. Also, you might see some blood at the urethral meatus or around the perineal region, things like that. Then interventions, you want your cannulas. Remember, we're resuscitating, so 2 wide bore cannulas. For adults, green and gray. For children, blues and pink as applicable. So put your cannulas in. While you're putting your cannulas in, remove some blood samples. You want to get a blood group, you want to get a hemogram,
You want to get a baseline UECs because with repeated reassessment, perfusion affects the kidneys, so you want to know where you're starting from. Then also in terms of muscle breakdown, rhabdomyolysis, all that stuff. So you want to draw your labs while you put your cannulas in, then start with some fluids. Fluids, we want either normal saline, rigorous lactate. Current ATLS recommends you give a liter bolus. If that doesn't help improve your hemodynamics, you move to blood, okay? Another thing that you want, especially for patients who have significant bleeding, tranexamic, especially head injury patients, is another consideration, especially if the GCS is less than 15. So, and you're thinking they have intracranial bleeding. So tranexamic is important to give your bleeding patients. In the algorithm, you'll see the dose is 15 milligrams per kg over 10 minutes, then you give an infusion for 8 hours. Then it's been proven to improve your patient outcome. Then in terms of evaluation, this is where your POCAS comes in, point of care ultrasound. You want to do your extended fast. You check all your abdomen and pelvic windows, check your pericardial windows and also your lungs. You want to see is there any blood where there shouldn't be, any free fluid where there shouldn't be, which in trauma is blood. And if it's positive, that's an alert you need to give your surgeon. And then a positive, fast, plus unstable hemodynamics despite resuscitation is an indication for taking the patient to theatre for an X-lab. Okay, so let's remember that. Then if your pelvis is unstable, you want to put a pelvic binder, which you can just use even bed sheets in the hospital and close them. If you have an actual commercial pelvic binder, that's also fine. But there's really no excuse not to put on a binder because pelvic bleeds can be massive. Then we go to D, which is disability and neurological status. So you're going to check your patient's GCS. What is the GCS out of 15? What do their pupils look like? Are they both reacting equally? What is their sugar levels? If they're hypoglycemic, you want to correct that. Here you also give analgesia, right? So severe pain, you want your opioids, your morphine, fentanyl. You can also give, if they have open wounds, you can give your tetanus toxoid here, plus your antibiotics as well. Then make sure you check their temperature, keep them warm, because you're going to expose them as well, because you want to do a front and back evaluation, especially patients who've had like penetrating wounds or RTAs. You want to check everything front and back for any injuries that you might have missed, because sometimes they might also just be bleeding through the back. So remember to expose your patient, log roll them, check front and back, and then DRE as appropriate. So that's your primary survey with the different interventions at each point. Then after you intervene, you reassess as you go along. Once you complete your primary survey, you can do also your x-rays at that point. Those are your adjuncts. X-rays, ultrasound. You can put your catheter as well for urine output to check how well you're resuscitating. So those are important things to do at that point. Document everything. Sometimes at that point, you will know what your definitive care plan is. If it's a patient who needs to go to theatre, take them to theatre immediately. If it's somebody you need to transfer or refer to a different hospital, you can start that conversation already. And gather like all the stuff that you've done, and then move. Then now after that, we go to our secondary survey, which is a head-to assessment. You want to check for any injuries you may have missed that aren't life-threatening, maybe limb-threatening or slightly debilitating. So a head-to assessment, check for any lacerations, rib fractures, or bony fractures, dislocations, things like that, and document all of them. And then clean all wounds, open wounds, make sure they're cleaned. You can splint fractures and all of that. So that's the schematic that we use. Once you've done all of that, once your patient is stable, especially after primary survey and your patient is stable, you can take them for CT scan. They have to be accompanied. We will talk about this in our critical insights interview. So that's your trauma management algorithm. That's the sequence that you're supposed to do with your high-risk trauma patients or your major trauma patients. And that's what's supposed to be uniform with everybody.
Welcome to Critical Insights on Casualty Live, where we sit down with leading experts to unpack the decisions that save lives. Today on Critical Insights, we have the pleasure of being joined by Dr. Ivan Seno. Dr. Seno is a consultant general and transplant surgeon.
He has extensive expertise in surgical education, trauma care, and renal transplantation. Regarding today's topic, he's actually an ATLS faculty member and a course director and has contributed to the 11th edition. So who better than Dr. Sano to have a discussion with on trauma and the systematic approach to trauma patients? I hope you guys listen keenly to everything he has to say. He's going to give us a very nice in-depth breakdown on how to approach our trauma patients so that we can save a life and have very good outcomes. Karibu. Hi, Dr. Sano.
Hello, Dr. Wanjama. How are you?
I'm good. Thank you so much for joining us today.
It's a pleasure.
I'm so excited to talk about trauma with you.
Yeah, trauma is a big topic among all admissions in the hospitals and the care that we provide.
Yeah.
And so it is something that should be talked about more often and explained more.
So why is trauma so important in our Kenyan setting?
I think it's just off the basics, the fact that the burden is quite significant.
Okay.
The burden on the healthcare system, the burden on the population, and as such, it ends up being a topic that cannot be ignored.
Okay. Do we have any local data on how bad it is?
The data is sketchy. By that I mean we don't collect it in a uniform manner. Our desire is to one day have a national trauma registry, which will give us a lot more information. But what we have at the moment puts overall admissions, hospital admissions for the middle age or the young patients at around 60% of all the admissions being trauma related. And in as much as that is a high number, again, it also contributes to the number of those who actually die, which is again given at around 80%. But this varies in various regions, in various hospitals that are collecting data. And as we collect better, we might have a better representation of that information, but it shows a significant burden.
Yeah, that's quite a bit, especially when you think about it in that context.
I think it is a daily reality. I think it's one of those things that always keeps you on edge because, again, it's not preformed, so you're always on standby. And it can vary from a simple ebb and flow with one admission here and there to a mass casualty, shutting down a whole institution for 24 to 48 hours, just taking care of the injured.
Okay, all right. So in that regard, would you say it's not just an emergency medicine skill and like every clinician should be adept at taking care of trauma patients?
I think every clinician should be.
Okay.
I always go through the anecdote of what would you do if you saw an accident and you were driving by? Would you remove your phone and call the nearest hospital to come and sort it out? Or do you feel confident enough to actually stop and be the fast responder? And if you do stop, are you equipped well enough to actually make a difference? And whenever I ask that question, most people say, yeah, I don't even know where gloves are. I don't have a first aid kit, so I'll just call the next institution. I think as people who use vehicles, first of all, just first aid and basic life support is something that should be general knowledge. Not to pull people out of vehicles, not to turn people before the team comes, simple things that would make a difference. And then all healthcare workers should have the skills and the knowledge to be able to intervene early on from when they interact with the trauma, whether it will be on site or whether it's when the patients now arrive at the hospital.
Okay, all right. So since it's so common and time sensitive, what's the simplest framework or approach that we can use when these patients get to us?
The simplest framework is having one universal language. And while I mentioned the BLS, it's a basic life support skill. And then we have now the advanced trauma life support skills, ATLS. There is a version of ATLS that's catered or designed for our nursing colleagues. It's called the ACTN course as well. But why this is simple is we all speak the same language when it comes to the initial response and the initial intervention for a trauma patient.
Oh, okay.
Yeah.
So then that also means that we're moving away from leaning in on one individual having all the information to more of a team-based approach, right?
Yes. The evidence is overwhelming that institutions that have taken up team approaches have actually had better outcomes overall. that their mortalities are those who would have died regardless. But those who have preventable deaths and those who have disabilities have better outcomes when it is a team approach as opposed to an individual being the only one carrying all the information and knowledge and skill, then sort of administering this through the other participants by giving instruction or being the one to do everything by themselves.
Okay. So for someone who's never formally been trained in ATLS or is hearing it today for the first time, what are some of like the key points that it emphasizes?
It emphasizes a systematic way of assessing the patient. They have it broken into two, sometimes three groups. There is a primary survey, which is the initial assessment. And then as you wait for the definitive care, then there's a secondary survey to now gloss over and make sure you've not missed any injuries and make sure you've captured that. And in trauma institutions, once patients have been admitted, there is a tertiary survey to complete the documentation for the entire process.
Okay, all right. So what tangible differences does using a more structured approach than everyone running at the patient and doing whatever?
Well, number one is prioritization of injuries.
Okay.
From the most life-threatening ones to the ones that can sort of be delayed or controlled until definitive care comes in. Two, it's organized use of resources from the human resource aspect as well. And even just what you will end up utilizing is systematic. So that you're also not just throwing resources around and actually not having the impact that you would like. And then it affects the outcomes. Because if you're systematic, then you will miss less injuries, you will intervene at the point of need more accurately, and you will have better outcomes.
Okay, all right, that makes a lot of sense. So can you take us through step by step, like what are the key points that are emphasized in this approach?
So the simplest way to look at ATLS is figuring out what will kill this person before the other. And the reason for this is the theater of trauma can overwhelm you. And I'll give the example of somebody who has a loud bleeder. Now, by that we mean has a vessel and it's spurting everywhere. They'll catch the attention of everybody. But that's the guy who's less likely to die if he's screaming in pain, holding his leg and blood is spurting everywhere. He's less likely to die than the silent guy. So what ATLS does is it prioritizes the life-threatening injuries. And it does this through the mnemonic where we talk about the ABCDE. And they break it down to A being, airway with cervical spine immobilization. And the reason why this was coupled was over time, we were having issues where injuries, while airway was being secured, partial spinal cord injuries were being also converted to complete injuries. And so by virtue of that, they said it's mandatory to protect the cervical spine. And then a B problem comes next, with B being breathing and ventilation. So I could be taking breaths, but am I actually exchanging air? So then the priority there becomes making sure there is no life-threatening breathing problem, and then intervening and making sure that after you've resolved that, then the patient is ventilating. Then now comes circulation. In circulation, we have our blood pressure, we have our vital signs, and this is where now that loud bleeder would actually be addressed. Here we talk about hemorrhage control as well, so we try to stop the bleeding. There are many courses that have come up also, like the Stop the Bleed course, which now tries to go above and beyond, but this is now a more specialized training, like for the surgeons, trying to address better ways of controlling hemorrhage faster. Then D is our disability. So this is where we see if they have a head injury. We do the Glasgow Coma Score, and we also make sure that we have resuscitated them, because whenever we are doing a transfer to definitive care, we want the best GCS after resuscitation. So if you bring D early on, before you take care of A and B and C, you might underscore them, but it's just that your resuscitative efforts have not been significant. And then the last one is exposure and environment, where we now prevent cold, so we prevent the hypothermia. We remember to keep the patients warm. If you're extricating them from the injury site, keeping them in warm blankets, using warm fluids, warming the blood before administering it, but also exposing, so that as you focus on preventing the hypothermia, you don't have missed injuries, and you ensure that you've done a proper evaluation of this particular injured patient. In that sequence, there are some things that you can utilize. We call them adjuncts. So there are some areas you're allowed to bring in an X-ray, a portable, and you might be able to do an ultrasound known as a focused assessment with sonography for trauma. The adjuncts have to be mobile. They have to be able to come to the injured patient. And so we don't talk of CT scans here. We don't talk of the MRIs yet. And so if the imaging modality cannot come to the trauma bay, it waits until we have the person stabilized. So that's kind of the general language, and you'll find all around the globe, this is what is discussed when managing a trauma patient.
Okay. So let's talk more about the primary survey. So this, like you said, is the initial assessment. What are the goals in the primary survey?
The goals of the primary survey is to prioritize life-threatening injuries and intervene. So in training for ATLS, we do not only train how to identify, we also make an effort to train how to intervene, because it would be quite helpless of you to be able to see a problem and actually not be able to intervene. Like this is the issue and we can't fix it. So most of these courses come with some basic skills that are also life-saving. So it's given a mnemonic ABCDE in the primary survey, and usually you would start with the airway and C-spine control, and then it'll be followed by breathing and ventilation, and then followed by circulation and hemorrhage control, and then you have the disability with a neurological exam, and then you have the exposure and environmental control. In between those 5, you can add on some things we call adjuncts. So you can do some portable X-rays, and you can do a focused assessment with sonography for trauma or a fast examination.
Okay. All right. Let's get into more detail. So, like for us on the floor in the ED, when a patient comes in, take us through. They've been in an accident, it's a bad accident. Take us through like each individual step, like how we'd approach this patient so that we make sure that the primary survey is actually being done properly. What does that look like? So
usually, depending on who brings them, there'll be a small snippet of what happened, like a missed history. So mechanism of injury, what had been done on the field, if there was maybe some first aid, the interventions done, and if any treatment has been done. Because this also helps you know your starting point. There'll be those who are brought in by bystanders, unwitnessed. There are those who come already intubated on a spine board. That also means the resources distributed, again, would depend on how the patient has presented. So once you get that little summary, then you proceed to assemble a team. The desire for most institutions is to have an independent or dedicated team that responds to this. But what we teach in ATLS is that the ATLS provider at that point in time becomes a team leader. And as team leader, you kind of take the role of knowing what everybody can do. It's always going to be a team sport. And you at least know in the team you're working with who, for example, can do inline cervical mobilization, who can manage the airway, who can be the one who takes the notes and just journals everything that's been given, the radiographer who will do the X-ray. Then your responsibility is to start the review as you go, but also utilize these resources. So you can't have the airway being manned by somebody who, again, is not competent to manage the airway. You cannot be using the person who maybe is the most skilled to doing something like taking the blood pressure, as opposed to having them start. So we usually like to think of it as linear, where we would go A, B, C, D, but in the reality, during the time of trauma, many things move at the same time. We will have some airway happening. So the goal is to, again, have closed loop of communication. So if I've been asked, for example, there is a bleeding vessel, so I have delegated one person to put in pressure. So that's their role. They don't move from there. And they give us feedback and say, I've placed my palm and now I have control. So we know we are no longer bleeding. You then cannot ask that person to then go to the lab and do something. So you've already decommissioned that one person. So then we start at the airway. We want to make sure that the airway is patent. Most times we'll just speak to the to the patient and just introduce ourselves. And we listen to the quality of their response, if they're able to phonate well, and if they do not have any secretions or any foreign bodies. If we clear it well, we usually place them in a cervical spine collar. We use the hard collars mostly, because at least that also does not have somebody standing there maintaining. So then again, the utilization of resources. When we do the breathing, we would like to quickly listen. The reality is our casualties, our A&Es will always be a loud place, noisy place. So it also cannot be a very prolonged examination, because sometimes you're getting the echoes and the voices from around. So then you listen. You can also percuss, you inspect, so you see how they're breathing. So I know in E we speak about an exposure and environment control, but the goal is if you can get this patient fully exposed to then do a quick run through to then cover them up, it would be better. So then you've exposed the chest, you look for any wounds, you look for bruising, then you again palpate for any areas of pain and tenderness. And if the patient is coherent, they will be able to also tell you that's painful, this is that. And then there are special examinations that we want the clinician to do. So checking for crepitus, listening if there is present or absent breath sounds. So we don't ask them to try and tell us, are they rhonchi, are they rails? Just, do we have present or absent breath sounds? And then at this time, most of the cervical spine collars will also have a little window at the front. So then you can also look at their trachea and see if it is midline or shifted. Once that is again settled, we then now move to circulation. Like I said, we would like it to be linear, but by then you most likely will be having your vitals done. So you know your blood pressure, heart rate, and then also oxygen saturation. This information also helps you know if you're resuscitating well. And with the numbers that you get back, you can also be able to quickly place the patient in the category of shock where they fall, because there'll be some criteria that is taught during the course, so that if you know the heart rate is a certain number, blood pressure is at a certain level, and these are the saturations, and they're either awake or they are confused and all that, you can then say class 1, class 2, class 3 shock, and you can know what you're dealing with. This helps you then move to the next step. So from there, we also start interventions. In airway, if there's a problem, the skill will be trained on how to provide an intervention. You'll almost always be getting a definitive airway, which means intubation. The problems in breathing might require something known as a tube thoracostomy or a chest tube. Sometimes it's as simple as just a needle in the right position, decompressing the chest, and that can be life-saving. And other times it's just putting a dressing on a sucking chest wound. That also makes a difference. So you can see there'll be skills that are also taught at each level. Then at circulation, we start to give fluids. And with the class of shock that you have, the amount of fluid administered is also limited. The encouragement. Now, you know, on the ground, things are different. You'll say give blood after 1 liter, but most times blood is not available. But if you have already placed your patient in class 3 or class 4 shock, regardless of how much saline and lactated drinkers you give them, they need blood. And so you'll have to find blood. So sometimes the referral to the next facility can be just because of blood products. We have something known as a massive transfusion protocol. Locally, not many institutions are able to step up to the massive transfusion protocol, but almost all institutions will have blood products. So again, this will also be tailored to what's available to you and your institution. But once you know that blood products are needed, then they should also be looked for. With hemorrhage control, we also have now where the surgeon comes into play, because sometimes the hemorrhage control might require now transfer to the operating room. Might need a laparotomy, might need a thoracotomy. So again, we're back to the closed loop communication, making sure you know the abilities of your institution. So ATLS will always remind what are the capabilities of your facility. So if you're seeing this patient needs an operating theater and you know you don't have a surgeon, you don't have surgical capabilities, then ATLS will be teaching you to promptly transfer to the next facility, helping you to also identify who can we manage, who can we not manage. And once that has also been sorted, you then move to the disability. The preference, again, like I mentioned earlier, is disability would be done when we've at least instituted some resuscitation. So resuscitation just includes high flow oxygen, improving the blood pressure, bringing the heart rate down. This will improve cerebral perfusion. So then at that point, your best Glasgow Coma score at least is a representation of your resuscitatory efforts. So that you don't place somebody, say, at a GCS of 10, whereas maybe they were just hypoxic. And when you resuscitate them and take care of the tension pneumo, then they come back to a 14 and 15, because this also affects your channeling of the referral process. Then in exposure, we try to keep them warm after we've at least tried to make sure there are no other missed injuries. And then we might be able to introduce the adjuncts at this point as well, just to close up. At that point, you have the end of your primary survey, and you have an initial assessment, and you can provide a summary of the injuries and what needs to be done for the patient.
Okay. Wow, that's a very expansive, comprehensive summary of the steps that you go through in the primary survey. What are some of the common mistakes we make in the emergency department when we're doing our initial primary survey?
I wouldn't call them mistakes. I think our biggest challenge, first of all, is just how we communicate with one another. Teams that have worked for many years, they develop that cohesion, and the communication is a big factor. You know, when somebody has asked for something and they've been given a response, they're able to act on that. So our first step is just our interpersonal, being able to say, you know, we are the team, and this team is taking care of patient in bay A. So then again, you don't have people being pulled out of that bay to move to another bay, which means if another patient is wheeled in, a new team needs to be assembled. And then the other pitfalls is, as much as we want to think of it longitudinally, there's many things always moving. So sometimes we gloss over certain parts of the examination. Sometimes we don't tell each other, oh, I've done the first, it's positive. Sometimes you're waiting for the radiographer to come and do the x-ray, so everybody is just paused. And then sometimes our level of training does not also allow us to be able to impact by doing what is necessary or the next step. And that can also be quite frustrating, where you've already made the diagnosis in your head, but then the institution you work in does not support you to be able to do the intervention, because that becomes another challenge as well. So you'll have a patient with a severe head injury, needs to be intubated at the A and E, but then the ability to actually do that is not present.
Okay. Wow. And what's one step that's often missed in the primary survey?
This one will have to just be in my own experience.
In your own experience, yeah,
because we don't collect this. It's how much fluid we give at sea.
Okay.
I feel we always give way much more than is recommended by the protocol. But it's also because as a clinician, even as you're waiting for the blood, you can't just leave the patient. You can't just say they've gotten their liter and now we are waiting. And so almost always trauma patients will have gotten at least a liter and a half or two more than what is prescribed. And it's, again, just the empathy from a clinician. It's very hard to hold off giving something as you're waiting for another thing to come.
Yeah, that's true. And what are some of the risks associated with giving too much fluids to a trauma patient?
The challenge is we have, as you go through the course, there'll be a preaching of something known as a lethal triad, or the triad of death. And it's hypothermia, so that's why exposure is important. It's acidosis and coagulopathy. And once that triad starts to form, the risk of mortality gets higher. So coagulopathy is affected by the hemodilution because they are losing blood products. They already have significant hemorrhage. You're supposed to replace like for like. So if I'm losing blood, but you're giving me saline, it's really not meeting my body's physiology at the point of need. And then it's also not going to help with the acidosis. And so, and then if you're giving me non-warmed fluids, you're also pushing me again to hypothermia. So that act of desiring to make a difference, while might initially in the short term look positive, because maybe the BP will pick up, the heart rate will come down, it can then again have its own sequelae, where you now have the downside of it being the coagulopathy. Then now you start circling again the lethal triad of death.
That's a very interesting point. And how often do you find people actually fully expose the patient front and back?
So again, to be fair, it goes back to the mist. When we talk about trauma, and that's why trauma teams need to kind of be formed to then also have how they function.
Yeah.
So I'll give two examples. I have been stabbed once in the chest, and I have come to the A&E.
Okay.
If the
Not you, though.
I'm just saying the patients.
Okay.
But I'm saying if the clinician doesn't do a digital rectal exam, I don't think I'd fault them too much. But then if the same patient now was knocked by a matatu and they have a bucket handle fracture of the pelvis, that digital rectal exam offers a lot more information. That log roll and checking the spine and the step off also brings a lot of information.
Yeah.
So the best answer would be just do everything routinely so that you don't miss a step.
Yeah.
But sometimes as a clinician, you'll say, there's truly no information that we're going to gather from this intervention.
Yeah.
And so some of that will always get missed.
True.
The challenge is now when you're, for example, in an area where there's a lot of violence, war-torn areas with blast injuries, if you don't routinely get used to log rolling the patient, all that, you miss entry and exit wounds, you miss shrapnel. So I would still say just try to always be systematic.
Yeah.
And even if you don't do an intervention, document that we opted not to do this because we felt it would not add information. That shows that process was being followed, but it truly was not going to add value in terms of the physical exam and was not necessary.
Okay. So clinician judgment is not overruled by the systematic process.
It's actually supposed to be enhanced. Yeah.
Okay, great. And then, so while you were talking us through the ABCDE, some of the life threats are the ones that we're identifying, right? So in terms of your airway, what are you most concerned about?
You want them to be able to protect their airway. And this will always be based on a variety of factors. So for example, if you have massive facial fractures, facial injuries, your airway is just at risk because of foreign bodies, your ability to maintain your jaw, a position well. It could be because of the injury itself. It could also be local injury to the trachea and the structures, and that would need you to intervene. So when we are assessing, we want to hear the quality of the breaths. Are we getting gargling sounds? Are we hearing a stridor? Are we unable to actually get any exchange? Because sometimes they'll just not be breathing. Are we getting a proper response? But how does the response look? You think about, burns with inhalational injuries. If they already have the soot in their spit and they already have the stridor, you know that airway is at risk. So you can opt to just electively secure it when things are in good control. But even as you wait and you resuscitate, at some point that airway will be lost. So we usually look, listen, feel. And from just those three things, you should be able to know what you're doing and if you need to worry about it.
Okay. All right. So identify your life threat, treat as you go at each step. Okay. All right. And in terms of breathing, what are some of the big red flags that we should be looking out for?
We always talk about the tension pneumothorax. And in training, we always used to be told if you have an X-ray with a tension pneumothorax, then you shouldn't become a surgeon. It's a clinical diagnosis. They might make it. But it's when you're talking about the red flags, we already mentioned how the A&E can be quite noisy. So when you have your hypotensive patient, as you're moving to circulation, make sure it's not a B problem. And the tension pneumothorax will still give you hypotension just because of the mechanics of the compression of the heart. A cardiac tamponade would also still give you hypotension. A simple pneumo will not necessarily give you hypotension. A flail chest, in as bad as it is with the primary pulmonary contusions, will also not give you a life-threatening injury at that point in time. So we always worry about the tension pneumothorax. So our distended neck veins, our difficulty in speaking, our respiratory rate higher than 35, our silent chest, you should always think about it. And the recommendation is straightforward. It's a large bore needle at the area where you're going to place the chest tube. So even if you place and there's no gush of air, it's invasive, but it's a minor invasive procedure. The same way, if you place it and there's a gush of air, you've saved a life. So in the grand scheme of things, if you're worried, you're better off putting in the needle and getting the feedback and saying, okay, we've got an improvement.
Okay, cool. And in terms of circulation, external hemorrhage is easy to see, right? we can easily get distracted by it.
Yeah.
But internal is where we can get really bogged down, right?
Yeah.
What are some of the places where we can have internal bleeding that can cause life to be lost?
Yeah. So interestingly enough, apart from A, at B and C, you'll still be able to pick up on that. So it can be blood in the chest, blood in the abdomen, blood in the pelvis, or long bones, or on the floor.
Okay.
But the one you mentioned, if you're bleeding out on the floor, everybody will see that. The one that challenges us as clinicians the most is actually pelvic fractures, because even the way to give control to that is very limited. You place the binder, patient will respond very well, but if you don't have a definitive plan on how that will be sorted, the moment the binder comes off, they start to exsanguinate again. The one in the abdomen can be sorted through surgery. The one in the chest just requires a tube thoracostomy, and then if the volume is significant, then maybe a thoracotomy. Then our long bones, the shearing forces always destroy the periosteum and the bridging veins. If you reduce the fracture and place it in a splint, the bleeding stops. So the goal is to have that suspicion and to search for the blood in all those areas, and to not be contented or satisfied when you do not get a response. The caveat to that is if you have a neurogenic shock from a spinal cord injury, you really have to prove to yourself that it's purely just the neurogenic shock, that you've not missed a hemorrhagic
Process of elimination.
process of elimination.
Okay, great. And in disability, you mentioned GCS. Aside from GCS, what are some clinical signs that can tell you that there's something going on with the patient's neurological status?
We do check for neurologic deficits. So we see if there is unilateral weakness or if there's a discrepancy in how they're moving the limbs. But also this, we factor in the concomitant injuries. So if I have a pelvic fracture and a femur fracture, I'll not move the leg. And that has to be put into perspective. But we do check for lateralizing signs. We also examine the pupillary eye reflex. And that's why at least having a pen torch or light in the casualty is important. Or a phone, yes. Well, it's a torch anyway. But it's important because then the reflexes are good. We want them to be brisk. We want the pupil to constrict nicely. And when we have a discrepancy, at least it gives you a higher index of suspicion for an ongoing problem that would need further evaluation.
Okay, great. Awesome. And you've talked in depth about exposure, so I love that. So that's the initial assessment. But since trauma is always very dynamic, your patient, you could do your primary survey and think your patient is stable, right? Some of them can tank, right? Can change conditions. So what's the value of reassessing these patients? How often should we reassess? Should we repeat our primary survey, or should we be like, it's okay, we did it, let's move on?
No, so I feel, well, there is no prescribed timelines for reassessment. When we teach at ALS, and even in reality, we just recommend that every time you do an intervention, you go back and reassess from the start. So, for example, you've done your tube thoracostomy for a tension pneumothorax. You go back to airway. You start again. Are they still just talking to you? Are they still good? Has the B problem resolved? It could have been one side, now the other side has a problem. By the time you move to circulation and you're giving your fluid and then you get your blood products, you again reassess. So the goal with that is you're constantly being reminded to reassess. Once you've finished your primary survey, there should be a plan on where next the patient is going. And then now that translates to an admission, because we're either admitting you to the orthopedic ward, because now we need to go do fixation of the femur or the pelvis, or you have an open fracture, so you're actually being admitted through theatre. You could be going in for a trauma laparotomy, so again through theatre. And if you're going to the ICU or the HDU, you're on continuous monitoring. So there is no prescribed time to say, oh, reassess every 45 minutes. But if you look through the course, the kind of communication is, you just have to keep checking on this. You have to keep going back. The blood has gone in. We've given the first unit. What has happened? We're now on unit 4. What has happened? We checked the blood sugar. We are managing a closed head injury. Now they have a random blood sugar of 2. What have we done? After we gave the glucose, how are they doing? So it'll be very hard to say do it at every 15 minutes, because so many things are being done that you still need to keep reassessing. You've pulled the leg out, you've put them on a splint, you want to see what's happening. So by virtue of that, and then things like our spinal boards. We don't want them on those for too long because then they get pressure sores.
Yeah.
So then after you've done all that and now you want to log roll them and pull out the spinal board, you're still reassessing. After you've moved them, you're going to go back and say, how are you doing? Are you still okay?
Yeah.
You keep checking because like you've said, you could have glossed over a system unintentionally, or you could also have an evolving injury. I'll give an example of sometimes when we don't communicate well on our tube thoracostomies, somebody could place a clamp on it. So you already had done an intervention and you were better, and now somebody clamped it, it's not working. So as you continue assessing, you're wondering why the BPs again are going down. So then you have to go back, because you'll go to A, they're talking, then you come to B and be like, oh, we have absent breath sounds. And then you realize, oh, and then you unclamp and they get better. So if you say check every 20 minutes, the challenge becomes something could be missed. But the ethos is just reassess as often as possible until you've been able to hand them over to the next step of their care.
Okay. And are we chasing a diagnosis?
Never. Because the challenge with that is when you miss the diagnosis you're looking for, you kind of get stumped. The more generic you keep it, the more information you'll pick up. So that if you're sending them for a CT scan, it shouldn't be to look for something. It should just be to assess. So that if you miss your free air, you don't miss the splenic laceration because all you're focusing on is the free air. If you're thinking of an aortic dissection, if you miss that, you don't want to be unable to miss everything. So just do the scan as an assessment, a generic assessment, and then gather all the information that you get from there.
Okay. And in terms of our adjuncts, let's be honest, our local settings, sometimes you might not have the X-ray, you might not have the FAST. Do you have to lean on those to do interventions?
You don't have to lean on them, but you also have to have really good clinical acumen because some of our interventions are very invasive. You don't want to have a non-therapeutic trauma laparotomy, which becomes a second hit to this patient because you didn't do a FAST. And then, if you look at all the modules of all the editions of ATLS, we used to perform diagnostic peritoneal lavage, but it was removed because of the invasive nature and the false positives. So even if you were to say, okay, I don't have a FAST, I want to do a DPL, if you don't do the DPL well, you could still offer a non-therapeutic thoracotomy. You can also imagine if we do not have pneumothoracis, and then you say, oh, because I'm sending this patient out, I'm just going to put 2 chest tubes bilaterally. Those are also invasive procedures. We discussed earlier the burden of trauma. So the goal would be to champion for at least facilities to have enough of this adjuncts which are straightforward. So we're not saying the CT scan. We're just saying, can we have an ultrasound and we can just check if there is fluid? Can we do a chest and pelvis X-ray and a C-spine X-ray and just see if there is anything significant there? And this will also help us as we transfer the patient because then we communicate to the receiving facility with adequate information so that they know what they are receiving. Because sometimes you send another institution a lemon, they have no idea what's coming, and they're not ready to make they're not ready to make lemonade, so they also struggle.
Okay, all right. That makes a lot of sense. Now I'm thinking about the way you said moving our patient to CT scan. When do we make that decision to move our patient?
It has to be at the end of the primary survey.
Okay.
And they have to be hemodynamically stable. So that means you've reassessed them and now things are good. And then there has to be human resource to accompany them. So again, it's not going to be they've gone off with the porter alone. He's there wondering what's changing. And then the CT scanner also has to be ready for them. And the accompanying clinician should at least be able to again intervene. So we've stabilized the patient. We know because there are those who will be resuscitated in the operating room, whether it's a trauma thoracotomy that's needed or an ED thoracotomy, or whether it's a laparotomy. But by the time you've done everything from ABC all the way to E, you can now say we are stable, now we can go get imaging. Then you have to have somebody to accompany them. The change in clinical picture or the tanking of patients is almost always going to be in the CT scanner. Because again, if you don't have them with continuous monitoring, being supervised, so much movement has occurred. The chest tube has dislodged, the ATT moved forward. And that's why that accompanying clinician is very important.
Okay, makes sense. So the most fundamental thing is to do the primary survey.
Yes.
It's okay not to do the secondary survey.
You might not, or actually in many situations, you might find that your secondary survey comes after multiple interventions, might be in the ICU, where you get now time to do a proper head-to-toe exam.
Okay.
And the challenge is, as we've said, we're doing this on the go. So you can't again stop the trolley to say, hey, we haven't checked their glutes to see if there's a pressure sore, we haven't seen if there's a scalp laceration. So it'll be, we now need to go fix this pelvis. Maybe we are going to do an angioembolization. So the focus is, if we angioembolize the pelvic fracture, then they will do well. At that point in time, that has to be the next thing that's important. So you'll find, even in the times where we tried to set up a trauma registry, our biggest pitfall was when the secondary survey was being done. But when you look at it from a practical standpoint, you cannot stop the wheel to say, I now need to do a secondary survey. It kind of has to come when it comes. Yeah. And we always emphasize in ATLS, no delaying of transfer. So then again, you can't be the receiving hospital and then you say, if you haven't done a secondary survey, don't bring the patient, or if you haven't done a CT scan, don't send the patient, because the emphasis on this same language from ATLS is we do not do anything that would delay transfer to definitive care.
When should we be considering the transfer bit?
The moment you realize your institution does not have the capabilities to handle whatever trauma you've received, you should be triggering the referral process then, but not denying care. So, it cannot be, patient needs to be intubated and now you say, we don't have an anesthetist, so we won't intubate, because you're missing out on that golden hour. So if they have a severe head injury that's salvageable, that hypoxia is propagating secondary brain injury. Maybe the transfer is going to take 6 hours. That 6 hours has automatically affected the outcome for that patient. So even when the emergency team or the good Samaritans or the bystanders are bringing the patient, as you're evaluating, if you know we don't have what it takes, then you should be preparing for transfer.
Okay. You've touched on it. Let's talk a little bit about pre-hospital, right? What would you tell our EMTs when considering where to take the patient?
So we have to be careful how we answer this one. Some EMT services are cordoned off by counties, because the counties have, for example, taken up the services for the general population. And then our counties also have a kind of referral system. We do not have trauma facilities in our country. Actually, in the region, there are not many places that would say we have a trauma facility. So then the EMTs are at the mercies of our referral process. That means they go to the nearest facility and then get guided on where else to go from there. If we do get to the place where we have at least developed trauma centers, it'll be easy for an EMT to pick an injured person and know we're going to the level 1 trauma facility. So what I would tell them is, if you have access to any institution, always take them to the one you know has the capabilities to care for trauma.
Not a dispensary.
Not a dispensary. A dispensary is a good place and a lot can be done. So if I was walking from the pub and my face is slashed, I don't need to be brought to Kenyatta. The dispensary will take care of that. But if you watched me being flung in the air by a vehicle and I landed some 20 meters away, I need a trauma facility. So then if you bring me to the dispensary, even the way the care will be administered, tossing me from the van to the table and then from there to the next place, so many injuries will be changed from simple to complex, and then that golden hour gets lost in just that process. So if I know the facility doesn't have blood, if I know they don't have an operating theater, the trauma patient is most likely not going to get the care. So, but then at least pick a place where you know blood products are available. At least there is a clinician who can offer ATLS and then a theater. But that being said, some of them, it's not within their control. They have to follow the referral process. They have to go get a paper that says now go to the next facility, and they cannot bypass that.
Okay, that's quite interesting. I think also in the Kenyan context, a center that is capable of handling trauma has to have an OR.
Yes.
Okay. All right. What are some of the updates in the new ATLS. Now we're on the 11th edition.
We're on
We've
the
moved from 10th.
We're on the 11th edition. So this time round, we didn't have much.
Okay.
The 10th is where the 9th is moving to the 10th is where we removed DPL. So in 9th edition,
It's still there in the textbook.
so it's described,
Yeah.
but we no longer teach it as a skill.
Yeah.
And in the 11th, they're actually pushing away from even speaking about it. But the one thing that we kind of were laissez-faire as teachers of ATLS was we would kind of say, take care of airway, forget about the leader on the floor.
Yeah.
But now ATLS is saying we can at least put pressure.
Yeah.
And as much as that would sound like common sense,
Common sense is not that common.
yes, so that's what they have changed, is
Yeah.
that there is life-threatening examination, and that cannot just be ignored as we try to get the intubation done. Yeah.
Okay.
We're still doing 1 liter, then blood products.
And I also saw a part that they also advocate for whole blood.
Yes, we are moving back.
Yeah.
And the reason we are moving back is the 1:1:1 was also seen to be affecting coagulopathy.
Yeah.
And was also seen to be not as available. So we say like for like. So if I am losing whole blood, ideally I should be getting whole blood. So at the moment now, countries like ours that mostly has whole blood, we're doing very well.
Amazing.
Previously, we would feel bad when we didn't have, platelets and packed red cells, and we would like one day, but actually whole blood is key.
Works perfect.
Yeah. So to the general public listening to this, please go donate blood.
Yes,
Yeah.
but they were having a really bad blood shortage
Yeah.
lately in multiple centers, so that's important. Okay. If you could eliminate one recurring mistake when addressing trauma patients, what would that be?
The team factor. Our recurring mistake is we have domiciled skills
To
in
individuals.
one side,
Yeah.
and then caused a significant deficiency on the other side, but we are all expected to come together and serve the same. So the one thing that I would eliminate is the lack of skill, the lack of training, the paucity of knowledge. Because I feel if even that dispensary that we were mentioning earlier, if the staff there were trained, they would be able to guide that EMT much better, and they would know what needed to be done to get the patient ready for the next facility. But you can imagine if you're in that dispensary and you have zero training, you still have to offer service. You cannot turn away a patient. So the biggest mistake is just that we have knowledge silos. The one person, when they're around, outcomes will always be good. When they're not around, the system doesn't work. That one would be something that I would like to work on. The cost of training is high, unfortunately.
Yeah.
If I could, I would bring it down, but I cannot. But I think the availability of training has improved.
Yeah.
And if more people can be trained, and you can see like now many of the private institutions, when they are looking for employees, they are now mandating ATLS certification to be something that they want. And if we have more people trained, I feel it's going to be better. We have introduced in our undergraduate programs trauma course known as TEAMS, which is just a bit of an introduction to them to a basic form of ATLS and what the expectation is. And the reason for introducing this is they are going to graduate and become medical officer interns.
Yeah.
And previously, we could not offer ATLS to our medical officer interns. It had to be a MO who's completed. But at least with teams now, we're introducing the trauma language much earlier on.
Yeah.
So even as they are coming in as medical officer interns, they at least have some background knowledge. And as they continue to pick up skills and they continue to train, they at least know we need to prioritize this, then do this, and that is also going to make a difference. So the paucity of knowledge and skills is what I would like to fix as a recurring problem.
There's also the Casualty app where we give you step by step on what to do, and that one is free at least, and we're not discriminating on who gets to.
I think that's important,
Yeah.
and I think if there's one thing I've come to learn with how media works, if you just have a recurring video like in that Casualty TV, like over time you'll find so many people know what's next airway, what's next breathing.
Yeah.
And I usually laugh here when I tell guys, at least I know what to do in a fire, because everywhere I
there's
turn,
always fire,
there is
yeah.
pace. There is a pace poster, and then there is what to do and how to pass the fire. So at
Yeah.
least I know I can get the extinguisher and I
Yeah.
know what to do.
What
But
to
it's just
do.
everywhere I turn,
Yeah.
pace. So the repetitive use of the Casualty app would also impact that significantly, because then that way more people will just say, I think we should be doing this next. I think we should be doing this. And that
Yeah.
automatically will shift the whole process.
Amazing. Wow. Thank you so much.
Thank you
This
too.
has been a very insightful conversation. I know I've learned a lot, and I think our listeners will learn a lot. So thank you for the work you're doing. Thank you for joining us today. And we hope to have you again.
Thank you.
Wow, I hope that conversation shed a bit of light onto how we're supposed to be approaching our high-risk trauma patients. I hope we've learned a lot. And as we come to the end of our episode today, here are 5 things before you go. So first things first, trauma care is a team sport. Nobody saves a trauma patient by themselves, okay? Especially major trauma. No one can do that all by themselves. You need clear roles, you need a clear leader, you need a clear action plan. Once you do this, you'll be able to save time, work efficiently, and save the patient's life. And that's the main goal. Number 2, the best trauma care is well structured and predictable. Consistent use of the XABCDE approach ensures that you catch everything, address everything in a timely manner, and thereby you turn chaos of trauma into coordinated action. So number 3, don't chase a diagnosis. What you should be doing is treating the life threats first. So look out for what's going to kill my patient first and intervene appropriately. Is it the airway? Do I need to intubate? Is there a problem with breathing? Do I need to put a chest tube? Is it circulation? Are my cannulas in place? Does the patient need blood? Those are the things that you should be thinking instead of looking for, oh, what is happening? What is the diagnosis? Or maybe they have a splenic rupture. It doesn't matter. That is not the goal. The goal as the primary trauma team is to identify your life threats first and intervene appropriately. Number 4, reassess relentlessly. A trauma patient condition can keep changing every minute, every hour. So you have to keep reassessing to see what is changing, what is getting worse, what is getting better. When you intervene, is your intervention working, or is it making things worse? Do I need to change my intervention? Do I need to add something? So keep reassessing, because your patient condition could change at a moment's notice, and you need to be able to catch it and prevent them from dying. Last but not least, number 5, plan for definitive care early. The goal isn't just to make them survive the trauma bay. You want your patient to be able to reach their point of definitive care that will help save their life in totality, whether that's theater, critical care, or an interventional radiology suite. So not think past the trauma bay and where they're going to get the best care that's going to save their life.